All right, Kyle, who are you and who do you work for?
I'm Kyle McAllister. I'm the CEO of Triley. We're an AI company that helps clinical trial sites identify and enroll qualified patients faster, connecting to their EHR data. So we take trial criteria and use AI to basically read through charts really fast to find patients for those studies.
And so you're in the bulk fire community. Why do you guys use bulk fire?
So just quick background, I guess, maybe on me. So EHR background, worked for Epic and Cerner before getting into clinical research. And getting into research, I worked for a big site network called CCT Research, which is now part of IQVIA. So kind of lived on both sides of the like this access issue. We use bulk fire because what we use fire in general for trial matching. And what we're really good at is reading a lot of charts really quickly for really complex data. So we need breadth. And so a bulk fire is perfect for that. We need full population level information, meds, encounter summaries, and a lot of unstructured content like notes, PDF documents, chart summaries, that kind of stuff to find the right patients across huge populations, tens of thousands, hundreds of thousands, even millions of patients. And bulk fire is just the best option that provides us the ability to do that and scale it across, multiple customers as we're spreading out into this space. Uh, so it's great to have a standard that doesn't require us to custom engineer across every single health system.
Wow, that's great. Like it sounds like bulk fire is great for this use case, right? Must be smooth sailing.
In theory, it is. I mean, like the standard is solid in theory. What's in the standard today, like the baseline is pretty solid. It gets us a good starting place, but the implementation reality is very messy across vendors. So we've encountered pretty significant variation in how each of these vendors actually implements the spec. The same fire call can behave wildly different from one vendor to the other. Some are amazing, and we'll probably talk about those later, and some are really challenging. It really comes down to like versioning and configuration, and then even like to the specific individual practice that implementation is at can have settings that make it really difficult or make it honestly impossible to actually use those standards. Pretty much every EHR vendor that we work with, which is we do work all the way from like, the large scale Epics and Cerners of the world down to kind of mom and pops for some of the smaller sites that we work with. They all claim to have Fire APIs. It's on their websites. They have specs. They have developer accounts, like endpoints listed. But then when you actually go to connect the application, wildly different experience between them as far as like what does it even work or not. And then the other thing that I would call out is like unstructured data is still a major gap for sure. Notes and narratives, PDF documents that are out there in the clinical chart are there in some instances, but it's very spotty, and like the requirement of what it actually needs to be in the documents endpoint for Fire is pretty it varies pretty widely between EHRs. So it's really like each new EMR we onboard requires meaningful integration work. And, there's always this like trope that you do one and that's going to cover you across many others. But like, even inside of a single one EMR, from practice to practice, it can be a widely different experience as to whether we actually successfully connect or not.
How many EHRs roughly have you guys connected to? Like how
Yeah,
many?
we're in about, I actually don't know the number off the top of my head, but I would say like 12 to 15 different EMRs right now.
So yeah, and for those listening, Charlie is one of the more scaled in the community with that number because of these challenges. Okay, well, are there any particular? I guess you listed some particular blockers in terms of free text and anything else, but any other blockers you'd want to call out for the EHRs in the audience or other people
Yeah.
that are looking to be that are bulk curious?
Yeah. I mean, very concretely, it's kind of death. This is dramatic, but death by a thousand cuts, right? Like it's always just these all, you can get in and get connected, but ultimately there's like, you'll get in and there's a 404 error on the page when you try to trigger your exports, or you get in and pull it and it's missing headers on all of the data and you've got to go back to the EMR and get those things. And like I said, that can vary practice to practice, implementation by implementation. And so you can get there, but the time it takes to get there is often, wildly different. And it makes it really hard to commit to timelines for customers and, and deliver a really great experience for them. And then there are others where like, we have had EMR vendors where we've gone to connect to their API for a customer. And then when it comes down to it and we actually talk to, someone from customer success or somebody to actually help us connect to the EMR, they'll just flat out tell you like, don't use our API. don't use our FHIR API. It's not configured well, and you're better off trying to find another route or connecting to the data or getting an SFTP or whatever the case may be.
Here's a CDA document, you know?
Yeah, exactly. Yeah. I mean, yeah, there are a number that are really solid and work really well, but it's not like these are edge cases we're talking about. There are a large number of vendors that claim to have FHIR APIs that just like are completely non-functional.
If there's regulators in the audience or that see this afterwards, is there any change that you'd ask them to make at a policy level? Like if you could wave a magic wand?
I'd probably put the unstructured data access to the top of my list. Right now, regulation covers a lot of the structured FHIR resources, which is great. Like that's stuff that's super useful and it's extremely valuable. But AI just opens the door to the use and leverage of all this unstructured content. And so, structuring more around like what's required and what documents need to be fed through those unstructured, the document endpoint would be extremely valuable. I would say a close second to me though, and it's a toss up to me as to whether it's a second, is just stricter conformance around, I guess, testing for vendors that claim they have a bulk FHIR API. Like, are you actually compliant and can people actually use this API would be extremely helpful. The variance in how that spec's actually implemented is pretty widely different.
Gotcha. Okay. So like any praise for certain EHRs or for certain implementations that you can point to and be like, oh, that's actually a good example of someone in market today?
Yeah, I mean, Athena is crushing it. I mean, their FHIR API is consistently great to connect to. It's one that we can connect to in a matter of days and know that the data is going to be relatively consistent. There is variance in like how some of these folks document and where things end up, and so like that can't all be put on the vendor, but like pretty consistently solid API for Athena and their own proprietary API also plugs some of the gaps that are there for the bulk FHIR spec. One thing I didn't say, another item that would be super helpful is like starting to get into appointment data. We get requested all the time to be able to pull appointment data would be extremely useful in the bulk FHIR spec. So yeah, anyway, Athena for their bulk FHIR API and their proprietary API, like both extremely usable and great customer service experience. Modernizing Medicine has also been great to work with. We've connected with their API in a number of instances. It's really reliable. And they also similarly have a proprietary API that we haven't done as much with, but has been, easy to connect to. Those two have really been standouts. Like when we get a customer that comes through that's on one of those two EMRs, we're like, great, this is going to work. This is going to be great. It's going to work really well. There's others where when those come through, we're like, all right, we're going to fight through this together. It might take a little more time than we want it to, but we try to be pretty realistic about it. I think also I would just call out the fact that this exists is great, right? Like the broader FHIR community, it's amazing that, that this exists, that we're actually like talking to regulators about making it better. And so the fact that it's there is amazing, but yeah, better implementation would be super helpful.
You'd be pleased to hear that the regulators are ahead of you on the appointment piece because actually the new US CDI proposed to include appointments. Wild card, sort of curveball question I didn't send you in advance, but do you ever not use bulk? Have you ever hit a roadblock where you've had to do other data access patterns like transactional FHIR or a database connection or a flat file? Like, has it ever been so bad that you chose a course of action?
Yes. And like I said, we've actually had some EMR vendors literally steer us away from it to those because their FHIR APIs didn't work. We have had implementations that drug out for, months and doesn't end up getting anywhere. And we just have to cut bait and go do a VPN tunnel or set up an SFTP to transfer data on a regular basis. Or yeah, we've also had, like large CDA pulls for customers and made that work too. So the answer is yes, definitely. Like we've found ways around it, but it's so much simpler if we can go down the FHIR API path.
Totally. Well, any last thoughts about bulk FHIR or the bulk FHIR community and that you want to share with the audience?
Well, first of all, yeah, and props to Brendan for bringing together the bulk FHIR community that we've got to kind of work through these standards and push on making them better. But I'll just give a plug for the clinical trials community in this space. I think it often gets I don't think it gets talked about, but in our experience working with the community, the bulk FHIR community, it's actually one of the more prominent uses and one of the more prominent places that these standards are being utilized. And it's really critical, like if we're working in all cases where we have worked with an API that didn't work or drug on for a really long time, we're working with a provider, a principal investigator who wants to use our technology to find and enroll patients into studies for treatments that they need, right? At the end of the day, they're trying to provide a clinical care pathway to patients. We have oncology customers we're working with where it's like stage 4 trials, and the only option left for that patient is a clinical trial. It is care. And so when we can't connect to these things, it inhibits us from being able to actually like let that provider provide the care that they're trying to provide to their patients. And so just wanted to use this question as a plug for the clinical trials space. Like it's really important. We're heavy users of this, and we're live across the US, across a number of different EMRs, and we're optimistic it's going to get better, but tons of work to do.
Awesome. Well, thanks so much. Really appreciate it. And I know the audience appreciates everything that you've shared with us today. So
Yeah, thanks, man. Thanks to you for making a platform for it. It's huge.